Welcome back, and we are starting a very important session that is sharing the experience in COVID-19 regional perspective. And I welcome my co-chair, Dr. Nihal Abeysinghe, who is the president of the College of Community Physicians Sri Lanka. And we have a very eminent resource persons representing several countries: Sri Lanka, Malaysia, Hong Kong, Thailand, Taiwan, and Australia. So it's going to be a very important session where we share the experience from different countries. And I'd like to request Dr. Nihal Abeysinghe to introduce the first speaker. Dr. Abeysinghe.
Thank you, Indika. And our first speaker today are making the country presentation from Sri Lanka, Dr. Ananda Wijewickrama, Chief Infectious Disease Physician of Sri Lanka. Over to you, Ananda.
Thank you very much. First, I would like to thank the organizing committee for giving me this opportunity. In Sri Lanka, we had our first COVID patient diagnosed on 26th of January. That was a Chinese national. And the first local patient was diagnosed on 10th of March. By the time of August, we had 2,841 cases. That's for about a period of 5 months. And out of these, by that time, there were 250 odd active cases with 11 deaths. In Sri Lanka, we applied quite a strict quarantine process. From mid-March, first we decided to quarantine people who were coming back from Italy, Iran, and South Korea. There were many Sri Lankan expats who are working in these countries. And then for other overseas returnees were asked to self-quarantine. And then there was a travel ban for selected countries from mid-March, and the airport was completely closed down on 19 March for passenger flights. The government actions were headed with the direct involvement of His Excellency the President, and the COVID task force was headed by Director General of Health Services and Command of Army, and other committees were headed by key politicians, and there were several committees in the Ministry of Health. The quarantine facilities were handled by Sri Lankan Army. There were key decisions taken during the period of March and April. One is the lockdown of the country, then the closure of airport on 17th of March, then involvement of armed forces and the police, especially for contact tracing and running the quarantine facilities. And then when the case numbers went down, we started gradual reopening of the country. For the initial 2-3 months, there was a lockdown in most part of the country, and police was empowered to maintain the lockdown measures. During this period, only essential services such as health, water supply, and then the selected services like ports were maintained. Delivery of food and other essential items were arranged. Financial allowances were given to selected people. So by early part of August, the situation was this. Even though the total numbers went up, it was limited to 2,800 odd cases. And by that time, still the cases were limited to clusters. There was no community spread. The spread of clusters was controlled with strict active contact tracing and quarantining. There was a surge of cases as a cluster occurred in a Navy garrison, and then there was a rehabilitation center cluster. And but these were controlled well, and then the mobility restrictions were gradually eased off. So this is how we had cases, daily cases during this period. And you can see a couple of spikes in this period, due to Navy cluster, and the last one due to the cluster occurred in a rehabilitation center. But they were very well controlled. And then there were no cases reported from the community for 2 months. And then the day-to-day functions are started, but then unfortunately the people become complacent. And then we had another spike, which is still continuing. Now the case numbers are gradually going up, with the total cases ranging to around 28,000. However, when we consider these cases and the recovery, the Sri Lanka is doing pretty well, with the recovery rate of almost 73%, which is higher than the average global rate. And when we come to fatality rate comparison, Sri Lanka is again doing very well, with a fatality rate of 0.5%. However, I must say probably this number, the denominator is the total number of cases, including the asymptomatic cases. As we do a lot of contact tracing, many asymptomatic and mildly symptomatic cases are detected. These are detected by doing PCR testing, and initially in March and February the PCR tests were done around 50 to 70 tests per day, but then the case numbers were gradually increased, the PCR testing were gradually increased, and by now we do around 14,000 PCR tests per day, and up to now we have done almost 1 million PCR testing. Now this is for a population of 22 million. When we come to the management of these cases, at present the policy is to admit all cases, all COVID positive people to hospitals or intermediate treatment centers. That's for the purpose of monitoring and prevention of spread. Since the numbers are, even though that is going up, since the numbers are still limited, we can afford to do that. The asymptomatic and mildly symptomatic patients are in intermediate centers where they are monitored, and the patients with moderate to severe illness are admitted to hospitals for treatment and monitoring. There's quite active contact tracing using public health network, which Sri Lanka has a very good public health network, and also in addition to that, the state intelligence services also involved in this. And the quarantining of contacts is done either in their own house or in when it is not possible in quarantine centers, and they are monitored. And the testing of contacts is done if they develop symptoms early, or if not, at the end of 14 days. In addition, there's quite a bit of preparedness in the health sector with having more facilities with oxygen, more than ventilators, with stress on having more facilities with oxygen. And the ventilator facilities are developed in places where we are planning to have future intensive care units. And then we have to do a lot of work on reducing phobia and stigma. Then the guidelines are being prepared, and then there is the preparation for vaccine if and when it is available for purchasing, storing, and prioritization, etc. We encourage managing these patients. We have in these open wards, most of our old hospitals have this sort of open wards with very good ventilation and sunlight, and we can afford to do this in our climate, and I think it is a blessing to prevent cross infection, the hospital acquired infections, and also probably the outcome. At early March, the expert committee on clinical management in the country had several meetings, and with the available limited evidence, is decided to use hydroxychloroquine for symptomatic COVID positive patients, which we still continue in spite of lack of adequate evidence, I would say. Other antivirals are not recommended, not used, and aspirin, recently we started using aspirin prophylactically for high risk COVID positive patients, and also we use low molecular weight heparin for hypoxic COVID patients. And then there have been many other guidelines made on quarantining after exposure and discharging and so on. The present situation as of yesterday was we have had total confirmed cases reported of 28,580, of which 7,634 people are either in hospitals or in intermediate care centers. 20,000 plus cases have recovered and discharged from these facilities, and we had 140 deaths out of this, that is a mortality rate of 0.5%. However, we are facing with new challenges because of the gradual increase of number of cases. With intermittent lockdown of selected areas, we have been able to control the rise of these cases rapidly. However, still the things are still gradually rising, and then with the very active social media worldwide and in locally also, there's persistent fear created by them and stigma, especially created among general public, which is a problem in detecting cases and also interfering with normal day-to-day life. And of course, with the economic difficulties we have, as well as the world is having, We have to open up economic activities. At present, we have opened up many activities, but we'll have to improve. And of course, there's a plan to, for example, plan to start tourism from 1st of January. This has been a big blow to our country because in 2019, Sri Lanka was voted as the best tourist destination in the world. And when the tourism was started to bloom, we had this COVID, and as in many other countries, we had to shut down and stop tourism. But we are planning to start in from next January, and we hope with adequate restrictions, still it will improve, and many of you would be able to come to Sri Lanka and visit Sri Lanka and to see the place. Thank you.
Thank you very much, Dr. Ananda. We'll be taking questions later. However, if you have any questions from the audience, you can just type them in the chat, and our resource persons, they will answer whenever they are available during the session. So we'll move to the next presentation. That's from Malaysia, and Dr. Sanjay Rampal, Lekhraj Rampal, who is the head of department from the Department of Social and Preventive Medicine from the University of Malaya. He'll be doing the Malaysia country presentation. Sanjay Rampal, over to you.
Thank you, Professor. So just like to confirm that you can see my screen.
Yes, you can. If you can, yes, brilliant. Thank you.
Right. Okay, thank you. Hi, my name is Sanjay. I'm from Malaysia. I'm the head of the Department for Social and Preventive Medicine at the University of Malaysia. And I will be presenting some lessons learned and maybe a way forward for COVID-19 pandemic. So first of all, we get to the situation in Malaysia. So in Malaysia, we recognize that there will have been multiple waves of major COVID-19 outbreaks. And as you can see from this graph may look a bit populated at first, a bit busy, but it supplies a few important informations. Number one is it gives you the epidemic curve. And from the epidemic curve, you can clearly see that they have had actually two major outbreaks. And overlying the epidemic curve, we have also put the transmissibility, the time-varying reproductive number. So whenever the red line goes up, that means there's increase in transmission. Overlaying that, also there's this movement control order periods. This is periods whereby the Malaysian government has taken specific policy initiatives to prevent and control COVID-19 in Malaysia. And so you can see that we have one major policy initiative from the 18th of March to the 3rd of May, whereby at the bottom of the figure, you can also see a stringency index of the various methods, various activities that we can use to prevent and control COVID-19, including movement restriction, border control, work from home, so on and so forth. So as you can see that in March, the government actually instituted a very thorough lockdown, whereby they instructed most of the population to work from home, schools were closed, so on and so forth. This order was actually relaxed on the 4th of May, whereby you can see there's a decrease in number of cases, and in the 9th of June, we went into a period of recovery, whereby there was a relaxing of a lot of economic activities so that economic activities can start up. Now, from this epidemic curve, you can see that sometime in September, October, there was a spate of cases, and this spate of cases actually was introduced via importation through maybe laxity in border control, whereby there some importation of cases that got to one of the regions in Malaysia, and that outbreak then very fast spread throughout Malaysia. And as you can see on the right-hand side, is when we are having our current major outbreak going on. And in response to the second major wave, the government actually introduced on the 7th of October, they again increased restrictions, as you can see from the redness of the various stringency index, that whereby we were made to work from home, schools were closed, so on and so forth. However, the government has relaxed many of the travel restrictions and movement restrictions since this week in order to spur the economy. Now, in addition to the table, in addition to the figure, I'll just show you this figure. This figure is actually an interesting figure on population mobility. And if you look at the pillars of prevention, border control, movement restriction, physical distancing, hygiene, and personal protection. So with regards to movement restriction, you can see that whenever there is a community-wide quarantine or community-wide lockdown, movement is greatly restricted. However, it does come with a cost. It comes with a cost to financial, economic, and social cost. Now, trying to place Malaysia in the world is very interesting because sometimes the media, our national media, play up the incidence of COVID-19 in our respective countries. So trying to figure out our ranking in the world helps, and this is what the department has tried to do, whereby what we did is we ranked a certain number of countries using 3 monthly incident density of COVID-19 cases. And as you can see here in the first slide, that Malaysia ranked 101 in the March to May period, the 3-month period. And we currently rank 100 in the last 3 months. So relatively, our ranking has not changed, but when we compare with Southeast Asia, we can gain some insight into how the other countries in Southeast Asia have fared. And among them is Singapore has been a very good success story, whereby they had initial outbreaks, but they're currently ranked 138. And you also have these countries with low incidence, Thailand, Vietnam, and Taiwan, China, even Japan has been relatively low, right? Now, if you compare, you also have New Zealand and Australia, which are relatively low. But one thing you do notice with many of these countries with low incident density is they are very insular. That means they are either islands or countries with good border controls. Now, if you look at the Middle East, and here you can see how Sri Lanka fares. So Sri Lanka initially fared at 140, but they have been trending upwards in the past month or so, past few months actually. The trajectory of incidents in Sri Lanka is actually very similar to Malaysia in the past few months. Now, in addition to that, you can see that in the region of America and Europe, Malaysia does much better than them. And I think that this is one big takeaway that we have and that we can use when addressing the media. That the incidents in our respective countries may increase, but when you compare it relative to many other countries, many of the Asian countries are doing relatively well. Now, coming to lessons learned, I think one very important lesson that is out there is that public health services are essential, right? The infrastructure is essential, the implementation and the delivery of public health services are essential. The second lesson to be learned, and I think even the speaker from Sri Lanka has said this, is we need a whole of government approach towards prevention. In Malaysia, the government recognized this as a threat to national security. Thus, the response to this COVID-19 threat is coordinated by the National Security Council. They receive input from all ministries. They receive input from the ministries of health and all the other ministries. But the action per se, the policies per se, are released by the National Security Council. Now, in addition to that, one good interesting thing that we got here in Malaysia is that we have an official unified risk communication strategy. That we have been having daily briefings by the Director General of Health with regards to health-related matters. And at the same time, we have been having daily press briefings by the Minister of Defense on all other related policies and implementation of policies. So I think this basically is a very good risk communication strategy. Now, one thing though is that politics matter during this COVID-19 pandemic. This pandemic is here for long duration, right? So strong public health interventions require political support. Political support is affected by political stability, media representation of the national outbreaks and the global pandemic, and public opinion. I think this is very important, whereby not only the politicians are important, but the support is affected by various factors. We also have polarization of public opinion, typically globally influenced by political and philosophical outlooks. Now, social norms are heavily influenced by how our political leaders act. Now, coming to a very important aspect of this is the media, right? So for politicians to act, the support of the media. Sometimes the media may tend to present different perspectives on an issue. So it's very important that public health professionals come out and balance the media. So here the public health at the group of us have responded by giving better translation and media advocacy. We have set up a COVID-19 web page where up to now we have 331 posts on COVID-19 related matters. We have also developed a COVID-19 epidemiology for Malaysia dashboard, whereby the layperson, that means those not in the ministries, can get up-to-date information with various epidemiological indicators of the pandemic. Now, in addition to that, another very important lesson, I think, is that we are susceptible. And I think we may get this over and over again when we look at the different regions, is that we had a first wave, we handled the first wave well, we had a break, and then we have a second wave. Now, there is a narrative out there that the second wave is due to laxity or non-compliance of the public. I don't think so. I just think we are susceptible. So if we are susceptible, we are bound to get infected if the susceptibility there pre-exists, right? So the main point is that this pandemic is characterized and will be characterized by major outbreak that waxes and wanes. Future vaccination program may play a role, but actually there's a lot of uncertainty there. Now, another important point is community goodwill is limited. Population fatigue is real, and we should all be very aware of it. And so that it is very important for public health professionals to actually balance the intensity of our public health interventions based on transmission dynamics or based on burden of disease. Now, this is another very important point that doesn't get enough headlines, is the limitations of a science, right? The limitations of a science. The science of this disease is evolving. I frequently see very strong causal interpretations of research findings, and we should be very careful of this. There's a lack of acknowledgement of the uncertainty of the science. In addition to that, we also have polarized interpretations, which may be biased by the classes of how one perceives the evidence. Now, another important point is vulnerable populations and collateral damage. We must all acknowledge that policies unequally affect our populations. Vulnerable populations are more affected by our policies. An important point is closed system dense populations, such as prisons, detention centers, and hostels, need to be supported and protected, because when there is an infection imported into this closed system, the transmission is unabated. The transmission is very high. We also need to emphasize modifying socio-ecological factors rather than just concentrating on individual responsibility. Now, we also need to emphasize increased community disaster resilience, and we should acknowledge that there has been disruption of other national programs, NCD and CD, including immunization, due to the prioritization or over-prioritization of COVID-19. Now, the way forward that I see that we should be moving forward is, number one, we should balance the benefit to harm. We should take the cost into account, right? This is a long-term game we are playing, so we need a long-term preventive strategy, and we need to utilize, we need to develop sustainable approaches for the future. So with that, I would like to acknowledge many members and my doctoral students and my colleagues from the department who have contributed in one way or another to this presentation. And also would like to thank the steering committee for COVID-19 preparedness and response at UMMC. Thank you very much.
So good afternoon. My name is Peng. I'm from the University of Hong Kong. I am privileged to share with you our experience in response to COVID-19 in Hong Kong. So early this morning, Professor Pierre talked about science behind the interventions against COVID-19. In my talk, I will try to use population-based data to illustrate potential effectiveness of different measures in control of COVID-19 in Hong Kong. We have gone through 3 epidemics of COVID-19 so far, and now in the middle of the 4th wave. So up to yesterday, there have been around 7,000 cases reported. In the first two waves, most of the cases were imported, shown as these blue bars, while the majority of third and fourth waves were local infections, shown in red and orange. So actually in Hong Kong, travel-based, case-based, and community-based interventions have been implemented since January. But we have never applied territory-wide or district-wide lockdown measures. Travel-based measures are largely travel restrictions, border control measures aiming to control importation of infections. Compared to early last year, there have been more than 99% reduction in passengers coming into Hong Kong through the airport. And we suspended most of the land transportations between Hong Kong and mainland China. Case-based interventions were about case identification, detection, and testing, while community-based interventions are largely moderate physical distancing measures. We made use of contact tracing information to reclassify cases identified in Hong Kong into imported cases and those linked to the imported, shown here in bars. The cases linked to imported cases shown in red boxes. The red box, the blue bars, largely reflect the risk of transmission from importation, which was estimated as the effective reproductive numbers. We found very limited transmission from importation in Hong Kong after February, when mandatory quarantine and other travel-based measures were implemented. Approximately 93% reduction in transmission from importation was associated with travel-based measures used in Hong Kong, shown in the lower panel here. We have been conducting population-based telephone surveys to monitor population behaviors in response to COVID-19 since January. So far, more than 30 surveys have been conducted. We've seen a universal face mask wearing shown in the red dots here, and people in Hong Kong have been maintaining very good hand hygiene practices, shown as these green and blue dots. And I used a similar way to look at imported cases. We estimated the risk of transmission of local infections, because this part is the most worrying part for us to prevent, to control COVID-19. Work from home is one of the major physical distancing measures used during the epidemic waves. It appeared to be associated with 64% and 56% reduction in local transmission in the second and third waves. We're working on the data of the third or fourth wave. And the additional physical distancing measures also implemented in Hong Kong using in high-risk facilities, including service restrictions in restaurants, bars, gyms, and other places. These measures were associated with 64% and 18% reduction in transmission in those two waves. Actually, testing capacity for SARS-CoV-2 has been substantially extended in Hong Kong from a few hundred tests done a day in January to February to more than 10,000 a day in July to August. Hong Kong Department of Health has been conducting test and trace on each confirmed cases. All close contacts were quarantined in government-designated quarantine centers, but test and trace approach may not function very well when the capacity, manpower, and testing were challenged by fast growth in confirmation of infections. We actually noticed that during mid-July, there was a sudden drop in number of tests done with the samples largely collected from quarantine centers and community outbreak investigations, these missing bars here. This might be due to a short of manpower at that time in conducting contact tracing, we estimated that this disruption in test and trace were probably associated with about 30% increase in transmission during that time. Super spreading was a typical feature of coronavirus infections, including SARS and MERS. This phenomenon seems also to be observed in COVID-19. Using contact tracing data, we noticed that in the first two waves, around 1,000 confirmed cases, among which half were associated with more than 100 clusters. Among these clustered cases, about 60% relate to local infection, and the largest cluster shown here involved 106 cases, which could be traced back to several bars in the city. This single outbreak actually accounted for 10% of all cases identified at that time, and also about 1/3 of all local infections during the same time period. Based on these data, we found that around actually 70% of local identified cases did not infect anyone else. We inferred that 90% of SARS-CoV-2 infections were responsible for 80% of all local transmission events occurred in the first two waves in Hong Kong. Although transmission routes of SARS-CoV-2 have not been fully characterized, we are still very interested to know how much COVID-19 would affect children, given the similar characteristics of this virus to some other respiratory viruses. As part of the responses to COVID-19, all kindergartens, primary and secondary schools in Hong Kong did not resume after Chinese New Year holiday in late January until late May to June. There were no local cases in school-aged children until early July, when local transmission went up in the third wave. Schools actually were closed again on 13th of July. During the third wave in July to August, there were 20 cases identified in children, illustrated here. And many of these cases attended school while being infectious, but no other school-aged infections related to these 20 cases have been reported. It may suggest that multiple potential introductions of COVID-19 into schools did not lead to onward transmission, which sounds like good news. This might be because children, especially younger ones, could be less efficient spreaders of COVID-19, as suggested by other studies, or school-based interventions implemented in Hong Kong were effective in preventing transmission. So in general, our experience in Hong Kong indicated that epidemics could be suppressed without complete lockdowns. More specifically, travel-based measures were essential to reduce importation of infection. Work from home and other physical distancing measures applied in high-risk places were effective in suppressing local transmission. Given the observed super spreading events of COVID-19, attention should be paid particularly to risk of transmission in some high-risk settings, such as mass gatherings, bars and restaurants, etc. Face masks and test and trace are necessary, but may not be sufficient to stop transmission, as we noticed that many transmission events occurred in situations where masks were not worn, and the continuous expansion of testing capacity did not stop the spread. Transmission in schools seems to be less efficient, which needs a further investigation. So what next? Given the global situation of COVID-19, there would be continuous importation, so travel-based measures should be important. Government has to balance the health and economic need during this pandemic, and therefore may consider some risk-based measures, such as travel bubbles, constant introduction of importation, and undetected infections in the community make it possible to see sporadic local infections and outbreaks from time to time. So we also need better approach to identify local cases as early as possible. So lastly, the increased community outbreaks of acute respiratory infections due to other pathogens in this winter we observed in Hong Kong may cause challenges in control of COVID-19. This closes my talk today. Thank you very much for your attention.
Thank you, Dr. Wu Peng. I think we are learning a lot of important things from this symposium, the similarities between different countries and the importance of basic preventive measures. So I think it's a really good learning experience, and I request all the participants to make the maximum use of this valuable and precious symposium where the top national level leaders have joined together and presenting their country experiences. You can send your questions in the chat so that we can direct them to the resource persons. And now we are moving towards Thailand. Thailand is one country which actually reported the first patient very soon after China. But after that, Thailand has basically adapted to basic preventive measures and managed to control the situation very effectively. So I would like to invite a key person from Thailand. That's Dr. Tanarak Plipat, who is a Deputy Director General, Department of Disease Control, Ministry of Public Health, Thailand. Over to you, Dr. Tanarak.
Thank you very much. And thank you for the invitation to join such a very important session. I would like to share our experience in Thailand, starting from the beginning, and talk about what we have learned and what we are going to do next. And most of my presentation will be about the public health measure. I'm not going into the clinical presentation of the patients. Before, I would like to mention a little bit about what we have prior to the epidemics, and a lot of things that make us successful fighting the pandemic today has been established long time ago. There are a lot of things that we cannot just do it right now and hope that it will help us during this outbreak. For example, our primary healthcare programs was established more than 40 years ago. It was established in 1977. These programs was so fundamental, and it gave us village health volunteers. Currently, in the countries that have about 60 to 70 million people, we have more than 1 million health volunteers. Another very important programs is field epidemiology trainings programs, which started since 1980s. Our programs was the first one outside North America. So when talking about epidemiology capacities, we have been implemented these capacities long time ago. Although in the beginnings, we focus on the 2 years trainings of the physicians. Later on, we focus on so many different strategies. We have tier-based trainings that create several tiers for different level of technical expertise in epidemiology. These programs lead to more than 1,000 disease control units, which is an investigation teams. For the first phase of epidemics, we were able to investigate most of the cases that occur in the countries, doing investigation, doing contact tracing, using both disease control unit and also village health volunteers. We started our what we call national health security programs that create an access to healthcare for free for all Thai citizens back in 2002. This helped us quite a lot. So anybody who maybe contact COVID-19, they don't have to hesitate whether they should go to see the doctors or not, because they don't have to pay for the investigation and treatment. We have public health emergency programs initiated in 2007. This program put together all the components of public health emergency management together. And we initiate, or I would like to say re-engineer our emergency operation centers again in 2012. Those give us a capacity, very important capacity to tackle the epidemics. Another very important part that we have learned was that we have so many experience dealing with emerging infectious disease in the past. We have problem with SARS. We have to handle avian influenza H5N1. We have experience with Zika virus infection, pandemic influenza H1N1. All of this experience help us prepare for this pandemic very well. After we have SARS outbreak, we put together our Department of Disease Control Strategic Frameworks that has focused on public health emergency management, as I mentioned earlier, since 2007. We take care of the IHR capacities, and also we were part of the global health security's agenda countries that trying to help ourselves and others in improving the capacities that will handle the problem with pandemics. For the COVID-19, after we hear about the situation in China, starting with about 27 cases of unknown pneumonias in December 31st last year, we start to watch the situation carefully and monitor how many travelers from China travel to Bangkok and other provinces. On January 3rd this year, China report 44 cases, and after we collect the information about how many Chinese travel to Thailand, on January 3rd, we activate our emergency operation centers and starts the surveillance of COVID-19 among the travelers. If you remember, on January 3rd, the Chinese did not really say what caused the epidemics or pandemic yet. They announced it on January 10th. But by that time, Thailand already has a suspected case. The first cases traveled to Thailand on January 8th. At that time, we do diagnosis using an exclusion. We do a lot of testing on seropathogens. If they are all negative, then we are going to test them for family-wide coronavirus. And that make us be able to detect the cases even before the Chinese release the full genome sequencing of coronavirus. So after we initiate our emergency operations, we set up the goals or the target for controls by, we did not really expect that we are not going to have any cases in the country. So our goal was to detect the case very early and be able to to control the spread of the disease. We would like to minimize the case fatality proportion among cases and minimize the health impact of COVID-19. We wish to also mitigate socio-economic impact of COVID-19 as well. Those are our main three goals that we use during the preparation and also during the response phase. These are the timelines that tell about what happened. So on January 3rd, we have activated our emergency operation first at the Department of Disease Control. On January 8th, we have the first confirmed case arrived in Bangkok. She has fevers and were detected at the airport. And on January 13, we announced that we identified the first case, the first confirmed case. That are the first confirmed case outside China. In January, we have a few cases here and there. All of them are imported cases. Starting on February, we start to see the local transmission of COVID-19 in the countries. We are the second countries after Japan to report local transmission. So in February, we have a mix between the case, the import suspected cases and local transmission cases. Starting in March, we start to see a rise in number of cases, because we have 3 clusters. The first cluster was among the people who visit nightclub in Bangkok. Second cluster was among the Muslim pilgrims who come back from Malaysia and Indonesia. Most of them live in the deep south. And the third cluster was among the people who visit the boxing matches. There are 3 important boxing matches during the times. So after the increasing in number of cases, the Centers for COVID Situation Administrations was established and then start to work. The approach that we used was the whole of government and the whole of society's approach. Everybody in the government and everyone in the societies will also participate in the planning and in the execution of the plan. On March 24th, the government declared state of emergencies. If you look at the epidemics curve, you will see that the declarations of state of emergencies occur after the number of cases was peaked already. On April 3rd, we implement the curfews, and early on April, we also have the travel ban. That is, anybody who would like to come into the country need to ask for the permission, and we ban all the flights that will land in Bangkok. On May 3rd, we start to ease the lockdown. And our last case of the first phase occurred on May 25th. After May 25th, we went about 100 days without any confirmed case. We start to have case again, reported confirmed case again. That is the local transmission on September 3rd. That was the sporadic cases that we detected. We started to identify cases here and there, but not very frequent. Most of the cases are the people who travel from abroad and enter the quarantine facilities. So most of the number, when you look at how many Thai reported the new cases, almost all of them were travelers from abroad and were detected at quarantine facilities. Recently, after Myanmar has epidemics, we start to have problem among at the Thai and Myanmar borders. First, we have the drivers from Myanmar detected at the borders. Then we have problem with some illegal migrants, immigrants from Myanmar. Recently, we have Thai returnees from Myanmar and Malaysia detected as cases. Currently, the Thai returnees from Myanmar who came into the country illegally, 30 of them were detected as confirmed cases. And those 30 has also transmitted the disease to Thai as well. We have 2 local transmission from the Thai returnees from Myanmar. Just this week, we start to see the transmission within the quarantine facilities. One of the first transmission we observed was among the travelers. And this week we have the transmission from the travelers to number of healthcare workers. But those has already been identified, and all the cases recently has been investigated, and hopefully we will be able to control the situation that we are facing at the moment. In July, after we control the first phase of epidemics, we request and we work with the WHO to come in to do an external intra-action review. And these are the success factors as reported by external evaluators from the WHO. Thailand's success factors include strong leadership. This I would like to say at all levels, from the Prime Minister down to village level. Those leaders also use the best available scientific evidence to guide their decision and guide their policy and measures. Secondly, we have a very strong and well resources and inclusive medical and public health systems. Third, we have consistent and transparent communication leading to compliance to public health measures. These are very important. After we initiate the Centers for COVID-19 Situation Administrations, we have focused on communications, and communication come out directly from the office of the Prime Ministers. We have a very good administrative system so that we can adjust our work and our administrative within Ministry of Public Health and other ministry, so that we can have surge capacity to deal with COVID-19. The previous experience, as I mentioned earlier, also are major factors in working with COVID-19. And of course, we use whole of society approach. That include academics and also the private sectors. These are the success factors that was reported out from the WHO IAR interaction review. WHO also recommend that we should also improve on several areas that we are not perfect, and we know that. For example, we should work on improving in our information, especially moving from information for action. Our information are good, but not as fast as we would like to have. We need to work more in protecting health workers and also patients, since we have a few nosocomial infection in the first phase. We need to improve our detection. We need to strengthen our laboratories. We need to strengthen our workforce. We need to strengthen our quarantine programs. And we also need to enhance the coordination even better than before. Currently, Ministry of Public Health itself work on several issues. For example, we would like to strengthen our port of entries, quarantine facilities, as recommended by the WHO as well. So we would increase the number you see is the number that we would like to increase to. We currently have, as I mentioned earlier, communicable disease control unit, 1,000 communicable disease control unit. We would like to increase those number up to 3,000 to 5,000, and we are implementing those capacity strengthening as I speak. We need to increase the number of ICU beds up to 1,000 and 1,000 to 1,300 beds, and hospital beds as well. So these are our plan to expand our capacity so that we can handle if we have any second wave occur in the countries. We are trying our best to prevent that, but we all know that if we are not very careful, then it can happen to us. Another issue that we are currently working on is to balancing the health and the wealth. These are very important. We have been working very well on preventing the health of the population. We are planning, and the government is also working very hard to improve the wealth of Thai people as well. This will be very hard because of the situation, not just in Thailand, but worldwide. As I discussed, we have been working on this for quite some time. It's almost, when I talk with the media, I would say we are very close to 1 year anniversaries. Starting from, if you remember, well, we start our operations in January 3rd. So we are working on COVID-19 for close to a year now. And hopefully we will be able to mitigate the effect as we set our goals on, and also improve the economic situation in the country as well. I would like to conclude my presentation, and thank you very much for a chance to be able to share Thai experience with all of you. Thank you.
Thank you, Dr. Tanarak Plipat, Deputy Director General, Department of Disease Control, Ministry of Public Health, Thailand. And it's very impressive presentation, and congratulations to Thailand having good control from the initial wave, and you were very rightly you did the review to identify your weaknesses, and now you are strengthening your weaknesses. Thank you very much for that experience sharing. And next we will move to the last speaker today from Taiwan, Dr. Ya-Wen Betty Chiu, Taipei Medical University, Taiwan. Over to you, Dr. Ya-Wen.
Okay. Hi, everyone. I'm Betty from Taipei Medical University, and my another hat is APAF Regional Director of Taiwan. It's a great honor to be here today. So I would like to start my presentation from this photo taken on April 14th. Outside the Grand Hotel, they show zero, Z-E-R-O, zero confirmed case. That's the very first day after 3 months of struggling. Taiwan celebrates the first day of zero confirmed case. And it showed the determination of Taiwanese people that we made it and we will work together. Okay, this is me. You can find me through the email, and we have a Facebook. And now I'm the director of Global Health Program, College of Public Health in TMU. Okay, so everyone knows the global situation now. There are more than 1.5 million of deaths already and still increasing. In Taiwan, we have a big wave in March, and so far we are doing okay. We have a total of 716 confirmed cases and 7 deaths. There's no locally acquired cases since April, no death cases since May 11th, and we are hoping to stop the second wave. And so far, we have 2 numbers, which are word number 1 from the bottom. Okay. One is the confirmed deaths, and another number is the economic decline. So I would like to share our 6 key factors learned from this COVID-19 pandemic. First, we learned from the SARS experience a lot. And since then, we stay high alert and do timely response. 3, we keep very good risk communication and information transparency. Do proper resource allocation and control the transmission prevention well with the tracking system. And 6 is the teamwork of Taiwan citizens. Okay, SARS is a bad experience, but good lesson to Taiwan. Okay, back then, more than 30 countries and more than 8,000 cases worldwide. And in Taiwan, we have 346 infected, 73 deaths. Among the number, 1/3 cases are actually health workers, including 11 deaths. And it's a very shocking lesson because a series of nosocomial infection were found mainly in hospitals, which means our border control was not functioning very well. Okay, so the outbreak was found in hospitals and caused $820 million economic loss. And back in 17 years ago, there is no cross-agency integration mechanism in government. We were excluded from WHO, lack of international support, and the hospital lockdown caused a panic among health personnel and the citizens a lot. This is a photo taken April year 2003. The sudden lockdown of Taipei Municipal Ho Ping Hospital, just shocking the whole society of Taiwan. The health personnel crying out from the window. They say, "We don't want to wait and die here. Please do proper isolation and the quarantine, separate the healthy and the unhealthy people." So since then, we started a lot of regulatory review and organizational adjustment. We amended Communicable Disease Control Act at least twice, and established the National Health Command Center. We learned that from US CDC and the Department of Health of the US. And this time, because of this good foundation, we can establish the COVID-19 Central Epidemic Command Center in a very short amount of time. And this is the structure of the NHCC, the Command Center, which is a cross-agency integration system with 3 sections, the logistics, operation, and the intelligence section, which is very special and led by the advisory group composed by experts and scholars. And the other sections are actually composed by high-ranking officers from more than 10 different ministries. So this CCC is actually led by a team of experts, and they made all the important decisions based on current and updated evidence. And this expert team continuously adjusts case definitions and the criteria for case reporting, revises clinical and the medical treatment recommendations all the time. And we are very lucky, our top leaders, there are several, one who has public health training and very well-known epidemiologists, including the former Vice President of Taiwan, Dr. Chen Jianren, and Dr. Lai Qing, the current Vice President of Taiwan, MD, MPH. Dr. Chen Qimai, the former Vice Premier, also with MD degree and public health training. So here in the APEF meeting, I would like to emphasize again that public health education really matters. And this is photo to show that our Premier Su Zhenchang visited the command center very often. And our President Tsai Ing-wen also supported the CCC a lot and visited the CCC many times to give full support and encouragement. Our President Tsai was recently elected by the Time magazine as one of the 100 most influential people in the world. And if I may quote, they said, "It's hard to find a world leader who's had a better 2020 than Taiwan President Tsai Ing-wen. She won re-election in January, oversaw one of the world's best response to the COVID-19 pandemic, and helmed an economic recovery." And when compared with these 2 gentlemen who was diagnosed with COVID-19 once and twice, I think our leader is pretty healthy and strong. Okay, so since we have high alert and timely response, it started from the New Year Eve of 2019. Taiwan CDC noticed information from social media indicated that there are at least 7 atypical pneumonia cases were reported in Wuhan, China. And we immediately called a press conference and started onboard quarantine of passengers on direct flights from Wuhan. This is the notice we cut. Okay, it shows that atypical pneumonia cases was reported with emergency notification. And this is announced by the Wuhan Health Committee. I have to say that we are very lucky because we also can read Chinese. All right, and we started very strict border control since then. We banned the entry of Chinese nationals from Hubei since January 26, including Hong Kong and Macau on February 11th. And we kept monitoring international situation and adjusting travel notices. And so travelers are subject to mandatory self-health management and quarantine for 14 days, depending on the country they come from. And we started to ban all the foreign nationals to enter Taiwan since March 19. Even the Taiwanese people on a charter flight arrive at our Taoyuan airport, and they have to be fully equipped with the PPE all the way before they get on plane and get off the plane. And all the passengers' luggage in the airport will be disinfected by the personnel. And we sent quarantine personnel to board on the sea cruise to carry out quarantine work and do physical examination. And here I would like to call it personal border control. Okay, Taiwanese people learn from the SARS experience. So they start to wear masks and line up to buy masks in front of the pharmacy to do self-protection, just in case the public border control is not functioning. So our command center hosts the daily press conference every day. And our capacity of 1922 consultation hotline has been increased. And we will post official outbreak situation and the updates on the official line and the Facebook accounts, and provide more than 6 different languages of promotional material to cover different groups of people, including migrant workers and foreigners, to make sure we leave no one behind. This is the photo taken in the command center daily conference, and we even have the sign language interpreter to help the deaf people to understand everything. And this is the command and also the Minister of Health and Welfare, Dr. Chen Shizhong in Taiwan. And he's kind of like a hero now. And we use our IT technique and link the National Health Insurance Database with the National Immigration Agency data to protect our frontline healthcare workers, so they can immediately aware of suspected infections based on the travel history and the symptoms. The e-referral platform added designated healthcare facilities for testing, and the MediCloud system also displays the notice when the testing has not been completed. We have a national IC card link with the mass distribution system, and more than 20 million people have purchased masks in the system from the open data platform. And we make sure the face masks were distributed to 22 local governments to protect the personnel in healthcare institutions, and coordinated with the producers to make sure the supply is always enough. This is the digital fencing tracking system I mentioned. Okay. The location of people in home isolation and quarantine will be monitored through the signal of their mobile phone. And if the signal is not correct or abnormal, warning will be sent to the people, to health agency, and to the police. And if they ignore the warning, the penalty can be up to 35,000 USD per person. And this is very useful measure with a legal base. And finally, I would like to give the credits to all the Taiwanese citizens, because most people understand the importance of personal hygiene, including masks, the washing hands, and also keep social distance. And now people know they have to take, when they take the public transportation, they have to wear masks all the time, and wear the mask when there's mass gathering, including the temple, church, the concert, and the Coliseum, etc., etc. Okay. So Taiwan government is investing more in R&D of the rapid test kits and related pharmaceutical products. And also we have 3 companies who are also producing vaccines for COVID-19 now, and all enter the phase 1 trial. Of course, Taiwan also signed the COVAX agreement and try to procure from other international pharmaceutical company of the effective vaccines. And our government invests in public health more than ever. And I would like to say that Taiwan is willing to share and cooperate with regional and global health partners all the time. And I would like to propose 5 dimensions that the roles we can play in the public health society, like APAF, and also all the universities and the research institutes. We can contribute in education, in research, and also raise the awareness and engagement of policy makers, provide innovative ideas, and also facilitate international cooperation. I visited Sri Lanka twice and met with Dr. Sunil always and Dr. Indika, who is a good friend to us. And I would like to visit this beautiful land again. Hopefully very soon with the effective vaccine is developed. And I would like to say, let the collaboration continue. Thank you for your listening. Still tea. Thank you.
Thank you. Share, Betty. So, okay, so let's move into our next friend, Colin, Professor Colin Binns. You can start your presentation after Betty. Professor Colin is one of the key public health resource persons in Australia.
Okay, just I've just temporarily lost my PowerPoint, but we'll have it here in just a second. Okay, can everybody see my screen there?
Yes, can you put that into slide share mode, Colin? Slideshow?
Yeah.
Yes, yeah, up nearby. Yes.
There we go. How's that?
Yes, great.
Okay, you caught me off guard just for a minute. This is just a brief presentation to explain to you what's actually happened in Australia. We've been very fortunate in that we have had a very mild epidemic here compared to some of the other countries. I'll show this slide again tomorrow, but you can see if you look at Western Australia where I live, we've only had 775 cases and 9 deaths compared to some of the other countries, because we've only got a population of just under 3 million people. Overall, Australia has had around 900 deaths from COVID. Cases in Australia, we had the initial epidemic, and then in June we had a number of cases which resulted from people spreading the virus while they were actually in quarantine. We have a policy of anybody coming from overseas, and that's a very limited access anyway, spends 14 days in a hotel under quarantine. But unfortunately that broke down in Melbourne, and we had this large spike in cases, all originating from a handful. As in most other countries, the peak of contracting the virus has been in young adults, since they're out and about and communicating socially. But of course, as with other groups, the death rate in our population has been mainly amongst the older folk and those who have chronic disease. In Australia, the number of cases has varied from state to state. As I said, there was a breakdown in quarantine in Victoria that led to the rapid spread throughout community and an increase in number of deaths. Whereas in Western Australia and South Australia, where we have very strictly enforced quarantine of all cases, secondary outbreaks did not occur. You can see in Western Australia, we had no local transmission for the past 240 days. These sporadic cases, this, for example, this peak is only 3 cases here, have only occurred on overseas arrivals or on sailors on ships that arrived in our ports. So you can see the source of cases here. The red represents the cases coming from overseas. These are airline arrivals and shipping arrivals, and locally transmitted cases. It's just this small band of purple at the top, which hasn't been expanding. So what we have done, we've put into force good public health practice, the detection of as many cases as we can, which has been almost all, as shown by community serology surveys. We have extensive, accurate diagnosis facilities. We enforce strict isolation of cases. If, for example, you come from overseas and you are confined to a hotel and somehow you manage to get out of that hotel, you then spend the rest of the quarantine, which you start over again, in prison. It's not a very pleasant way of escaping for a night's party or something like that. We've had strict travel bans. We've banned flights coming from overseas, except in very limited circumstances. We closed all of the borders for our states, and in Western Australia that means if you want to come into state, you've basically got to walk through 1,000 kilometres of desert, and that's enough to put anybody off. We've had our strict 14-day quarantines and selected lockdowns, but in my state, life is pretty normal. We can go to the theatre, we can go to church, we can go to classes at the university, shopping centres open. At the moment, nobody in West Australia wears masks except me, because I try to put out a message. There's widespread use of hand sanitizer and social distancing is publicised. And we've been pretty good at communicating with the public. If, of course, we have another outbreak, then we'll have to reimpose stricter controls such as lockdowns. So that's a summary of the Australian situation.
Thank you, Prof. Colin. And with that, we come to the end of this very important session. However, due to the interest of time, we will not be able to take specific questions. Anyhow, if you have any clarifications, you can always send them in the chat so that we can divert them to the resource persons. And at the end of this very important presentation, I would like to thank my co-chair, Dr. Nihal Abeysinghe, and then Dr. Ananda Wijewickrama, who is a very important resource person in Sri Lanka related COVID management. And we have a token of appreciation for the resource persons who are present in here physically. However, maybe we can send some Sri Lankan tea to our overseas resource persons, hopefully. Thank you very much.